Drug half-life. Duration of time it takes for the amount of drug in the body to decrease by 50%, not percent, not milligrams, etc. Use this to determine dosing intervals to maintain a therapeutic range. Bioavailability. Ability of a drug to reach systemic circulation from the site of administration, also known as the absorption rate, can be altered by disintegration time, enteric coating, and sustained release formulations. Differences in bioavailability occur with most PO meds. The biggest concern is bioavailability occurs in meds with a narrow therapeutic range. A small decline in drug level can cause therapeutic failure, and a small increase in drug level can cause toxicity. Therapeutic index is a measure of a drug's safety, not the therapeutic drug level. It is the ratio between a drug's lethal dose, which is LD50, average dose that it's lethal to 50% of those who take it, and its ED50, which is the average effective dose. A large therapeutic index is safe. A small therapeutic index is unsafe, because doses needed to produce therapeutic effects in one person may be lethal to another. The hepatic first-pass effect. Rapid inactivation of a drug by the liver when drug is given PO. Any drug that is given PO and is easily metabolized by the liver can be completely inactivated on its first pass through the liver, resulting in a non-therapeutic effect. Avoid the first pass effect by giving meds parenterally. For example, nitroglycerin. Off-label use. Use of a drug for something other than what is approved by the FDA. Prescribing a drug for a reason other than what is listed on the label or in the drug information guides. This is common and acceptable as long as it is prescribed based on sound reasoning and evidence. The CYP450 inducers and inhibitors. The CYP450 is a system of closely related enzymes in the liver. Three groups of CYP, A2, C, and A4 metabolize drugs. Metabolism by the CYP450 system may break down drugs into smaller molecules any molecule that activates cell receptors. Agonists bind to receptors and mimic the body's own molecules to perform normal body functions. For example, dobutamine mimics the body's own norepi, binds to receptors in the heart, and causes an increase in heart rate and force of contraction. An antagonist is a molecule that prevents receptor activation can increase therapeutic effects. Example, sulbactam increases the therapeutic effects of ampicillin, or can increase the adverse effects. Example, aspirin further suppresses blood clot formation. When combined with Coumadin, blood clotting is dramatically reduced, leaving individuals at risk for bleeding. Additive effect. Administration of one drug increases the effects of both that and the other drug. Protein binding, a key factor in distribution phase of pharmacokinetics. Most drugs bind to proteins or albumin in the blood. If the drug stay bound to the protein or the albumin, it cannot have a therapeutic effect. They must be unbound to have a desired impact on the target tissue. People with a high amount of protein in circulation, such as after a heart attack, surgery, neoplastic disease, and burns, will have increased binding of drugs to protein, which leads to a decrease in pharmacologic and therapeutic effect, and you may need to increase the dose or the frequency. People with low protein in the blood, who are hypoalbuminemic, liver disease, or renal disease, will need to increase the dose and the frequency. Lipid solubility, a key factor in absorption of pharmacokinetics. Higher lipid solubility allows a rapid absorption of lipophilic drugs through the cell membrane. Drugs that are not lipid soluble need to be carried across the cell membrane by other mechanisms. The majority of absorption occurs due to lipid solubility. The drug passes through the lipid bilayer of the cell membrane. Adverse drug reactions. Any noxious, unintended, and undesired effect occurring at the normal drug doses. They can be mild, such as drowsiness, nausea, itching, to severe, such as neutropenia, hepatocellular injury, cardiac dysrhythmias, anaphylaxis, or hemorrhage. Adverse drug reactions occur most frequently in the elderly, the very young, and those receiving multi-drugs. Some drugs produce organ-specific toxicity, such as amphotericin B in the kidneys, amiodarone in the lungs, aminoglycosides, the ear, and alcohol when combined with acetaminophen in the liver. The PCP should measure AST and ALT to monitor for elevation, which indicates liver damage. Other drugs can prolong the QT interval, increasing the risk for pertussis, dipointis, and VFib. Can be difficult to identify. Ask the patient, did the symptoms start shortly after the first dose? Did they reappear after starting it again? Did they stop when the drug stopped? Does the illness alone explain the symptoms? Are any other drugs present that may explain the adverse drug reaction? Categories of adverse drug reactions. Side effects. Nearly unavoidable secondary effects from any drug given at therapeutic doses. For example, drowsiness with antihistamines, gastric irritation from aspirin. Side effects are predictable, intensity is dose dependent. Toxicity, occurring from excessive dosing. For example, coma with too much morphine, hypoglycemia from too much insulin. Note, neutropenia from anti-cancer drugs is considered a toxic adverse drug reaction even though it occurs at therapeutic dose levels. An allergic reaction is a response occurring from prior sensitization of the immune system. The immune response can be mild itching, severe rash, or anaphylaxis. Bronchospasm, laryngeal edema, drop in the BP. The severity of reaction depends on degree of prior sensitization. It is not specific to the dose. Sensitivity can change over time. 10% of adverse drug reactions are allergic reactions. Most are to penicillins, the NSAIDs, and sulfonamides. The idiosyncratic effect is an uncommon response resulting from genetic predisposition. Succinylcholine typically, for example, succinylcholine typically produces short-term paralysis of the skeletal muscles. Those that are genetically predisposed have paralysis that is greatly prolonged. Iatrogenic disease is disease produced by a physician or a drug. Disease produced in this adverse drug reaction is nearly identical to a naturally occurring disease. Antipsychotic drugs that produce Parkinsonian-like symptoms, for example. Physical dependence develops over the long term with the use of opioids, alcohol, barbiturates, amphetamines. Abstinence syndrome occurs when the drug is removed from the system. Care providers should warn patients not to abruptly stop any medications without discussing it with the physician first to avoid abstinence syndrome. Carcinogenic effect, ability of a drug, environmental chemical to cause cancer. Teratogenic effect, drug-induced birth defect. One goal is to minimize adverse drug reactions by monitoring function of the target organ, for example, the liver, kidneys, or the bone marrow. Review med guides with patients, heed to black box warnings, reduce med errors by encouraging patients and their families to be actively involved with care, have a non-punitive work environment, use a barcode system for med administration, and fully complete a med rec form. Discuss important considerations for prescribing, including assessment necessary to choosing the right drug. What pathology are we trying to alter? What is the goal of therapy? What categories or classes are available to treat the pathology? How will the drug choice address the problem? What is its mechanism of action? What are the distinguishing features of specific drugs in this class? How is the drug absorbed in the body? How is it distributed in the body? How is it cleared from the body? What is the current up-to-date safety profile of the drug, including side effects, interactions with other meds, safety in pregnancy, and safety in breastfeeding? Always ask the patient, does the patient have any allergies? Are they taking any other prescription medications? Are they taking any over-the-counters, herbal, or homeopathic treatments? Are they taking any vitamin supplements? Do they take aspirin daily? And then you decide, will there be any interactions between the drug you want to prescribe and those in questions just ask the patient? Also ask, are they pregnant or breastfeeding? Do they smoke? Alcohol consumption? And are they taking any oral contraceptives? Consider the patient's age for the old and the young who have difficulty metabolizing drugs, which can lead to buildup and toxicity. Hepatic dysfunction. Less metabolism of any drug can lead to toxicity, and you may need to increase the dosage. Also, lower levels of protein, which may decrease binding capabilities, you may need to decrease the dosage. Renal dysfunction, poor excretion, may need to decrease the dosage. Low levels of protein decreases binding capabilities, also may need to decrease the dosage. Gender, body surface area, genetic predispositions to drug metabolism. Pause.